Welcome. The following is a presentation intended for people who work in the medical field, but much of what I will discuss applies to the general public. Grand Rounds is a common type of presentation in medicine that dives into a clinically relevant topic, presents cases, and provides practical information clinicians can use in their practice. I chose to put this presentation together because antinatalism is a topic few clinicians are familiar with, even though it has the potential to do a lot of good in medicine. I have no financial conflicts of interest related to this topic or presentation. It goes without saying, though, that I am an antinatalist, and this means my take on the subject of this talk is biased. Of course, it would be hard to find anyone who is completely agnostic and unbiased on this issue, since most people are pro-natalists and thus would be biased in the opposite direction. Take a moment to think about it. Think back to all the patients you have witnessed suffering, all the times you have helped them alleviate this suffering, sometimes successfully, sometimes in vain. As a medical student, I witnessed a cyanotic newborn die before her mom had a chance to hold him. As a resident, I held the hand of a dying woman in the ICU with an inhumane number of tubes and lines coming out of her body. As an attending, numerous patients have shared with me how miserable getting old and disabled is. For most of my career, I didn't have the mental framework to realize that these and every scenario of disease and suffering could have been prevented. The way to do this is incredibly simple. Yet, sadly, few people actually take it seriously. I would like you to walk away from this talk not only with a lot of food for thought, but also with some tools to do something concrete with this new information. I'll go over the term antinatalism, show how it is medically relevant, most critically in the prevention of suffering, and how to implement these principles in clinical practice, and ideally everyday life, in an ethical manner. Let's start with the term antinatalism. Although the concept has been around for millennia, there's no universally agreed upon definition, largely because the term didn't get coined until relatively recently. I would define it as a philosophy claiming it is unethical to bring sentient life into existence due to the inherent suffering and eventual death imposed on that being, especially considering such an imposition occurs without the being's consent. It is important to know this definition presupposes two very important things. One, that suffering and death are harms worth preventing. Thus, imposing them is unethical. Two, that imposing a harm on someone without their consent is undesirable. Obviously, a being cannot give consent before coming into existence, therefore this harm is always imposed without consent. In contrast, pronatalism, or more commonly natalism, claims it is ethical and desirable to bring sentient life into existence. As you might imagine, this philosophy has massive implications. So I want to spend some time here recognizing that antinatalism can be very hard to internalize. It challenges societal norms, cultural beliefs, and perhaps even what one considers the meaning of life. There are some hard truths we need to contend with. First, sentient life itself has inherent harms. Second, once brought into existence, a sentient person will suffer and eventually die. Third, ethically, those responsible for that person's conception are responsible for his or her suffering. Now, by this, I mean they are undeniably responsible for the person being put in harm's way in the first place, not necessarily that they imposed all specific harms themselves. We could spend hours dissecting all these points and unfolding their implications, but my point here is to lay out the basic premises to highlight that if we admit these things are true, we have some work to do as medical professionals who care about people. Despite antinatalism being logically consistent, medical professionals are just as susceptible as anyone else to reject the philosophy based on previously held beliefs. But if we really mean it when we say we want to reduce suffering in an ethical way, we can't ignore antinatalism being a way to do this. Preventing or minimizing harm is one of the top priorities in medicine. Whenever we give a medical recommendation or administer a treatment, reducing harm as much as possible should be one of our most important guiding principles. Our job as medical professionals is to help reduce and prevent suffering. Much of our energy is spent in attempting to delay death, presumably in most cases for those who want that death delayed. Although the actual indefinite prevention of death is not seen as realistic for currently living people, death can indeed be prevented simply by preventing conception in the first place. I will discuss consent and patient autonomy in more depth later, but few would argue against the importance of patients being able to understand and give permission to any intervention that affects their bodies. Consent is central to ethical antinatalism. So, medicine and antinatalism have very similar goals. Most of us went into the medical field to help reduce suffering. If we as medical professionals are serious about reducing suffering, we should also be serious about ethically preventing it altogether. As you have already figured out, the prevention I'm talking about does not apply to current people, in the sense that we'll be able to prevent death and suffering for them. Rather, this prevention applies to potential future people. I would argue contraception is one of the most valuable human inventions. Avoiding conception is the only guaranteed way to prevent suffering and death. As clinicians, we should use this tool to its full ethical extent. I won't go into the specifics of counseling patients through all the possible contraception methods, but I wanted to point out the variety of options we have. At the top of this table are the most effective methods, not including abstinence. The risk of pregnancy noted here in the first column refers to the number of women out of every 100 who have an unintended pregnancy within the first year of typical use of each method. The term typical use is distinguished from perfect use and refers to the failure rate in the hands of an average user that may not always follow the instructions of use perfectly. Therefore, this quoted rate of failure is higher than that for perfect use, which assumes perfect adherence to instructions but still has risk of failure due to the margin of error inherent in the mechanism of the contraceptive method. The table here lists methods approved by the FDA in the US as of this recording. There are a few other male contraception options in development, but those are not yet widely available. Speaking of which, as you may notice, most of the methods listed here are for women, but this, of course, is not a reflection of whose decision matters more. Sorry to state the obvious, but a lot of people seem to forget basic biology. I find it frustrating when contraception counseling focuses on women as if they were the only ones responsible. Even some electronic medical record systems are set up such that it is assumed that contraception is only a women's health issue. Contraception counseling should be part of every patient's regular care if they are biologically capable of reproducing. Normalizing this is step one. Without patient autonomy, we lose all sense of ethics in medicine. And as with any medical intervention, consent is key. Our job in the clinical setting is not to proselytize, but rather to inform and present options that make both medical and ethical sense based on our expertise and knowledge. We should stay as far away as possible from coercion. Let's remember that contraception counseling is standard of care. We are not talking about earth-shaking or unorthodox practices here. We are simply making sure we don't forget to do one of the most important parts of our job. Because there are so many pregnancies that happen due to poor or no contraception adherence and are unintended, part of the counseling of patients involves pointing out to those who don't plan to conceive in the immediate future that this is their desire. If a patient is sexually active with the opposite sex and does not intend to conceive within a year, we should make sure they have a reliable form of contraception. I'll go into various examples to illustrate this in a minute. Just like we have recommendations for people to stop smoking, we should have recommendations for people who don't plan to reproduce. Ideally, we should make a strong recommendation based on the patient's values and give them the tools to carry out this recommendation. We'll start with a simple example. We have a 25-year-old male with no significant past medical history who presents for a physical and has no specific concerns. As part of a physical, you can use a checklist of general health screenings to go through and not miss. On the left is an example of a generic list for women and on the right for men. These are based on the U.S. Preventive Services Task Force guidelines. Many EHRs allow you to keep record of a list such as this easily accessible and customizable. So this is one way you can include contraception within your own list of items to discuss. The beauty of a list like this is that if you don't get to something on your first visit, you can always have a reminder to come back to it at the next appointment. Everyone has their own style and flow. So the timing of when you introduce this topic is up to you and your patient's health priorities. You can start by normalizing this topic and saying, as part of your physical, I'd like to address some routine questions. Have you been sexually active within the past year? Are you sexually active with men, women, or both? At this point, the line of questions depends on the relevance of the biological possibility of conception. So you can ask, do you use any form of contraception? Of course, reduction of STIs may still be pertinent, so condom use could still be addressed. If the patient is using reliable contraception, you may decide to move on to other topics. However, it may still be worth pursuing the next set of questions for future options. You may ask, do you plan to have children within a year? And do you plan to have children at some point in the future? I'm surprised by the number of people in my practice that say no to this second question and yet do not use a reliable form of contraception. These people may be those who have never had children or who did have children but don't plan to have any more and are still biologically capable of having them. I would say this is the population that we can do the most for in preventing unplanned conceptions. As you may have already encountered in your practice, there are those people who have not really given any serious thought to these questions. This is yet another group of people we can greatly help. Lastly, it is important to point out that if the patient expresses desire to have children, and there are no standard medical contraindications to this, respect for autonomy dictates further discussion of contraception be tailored to that patient's values, such as timing of planned conception and the like. Although by no means obligatory, if the patient does not plan to have children in the future, permanent contraception options, such as vasectomy, should at least be considered. For the next case example, we have a 35-year-old woman with type 2 diabetes, hyperlipidemia, and tobacco use. She is here for regular follow-up, but hasn't yet had a physical. In this case, her medical conditions should be addressed first, and afterwards, if time allows, her general preventive healthcare measures should be addressed. This should include contraception, if biologically relevant. I won't go into the nuances of choosing contraception options in the setting of certain medical conditions. However, I'd like to use this next example to illustrate something that mainstream medicine tends to ignore, and that is informed consent when it comes to the risk of pregnancy. This 28-year-old woman with obesity and hypertension is interested in discussing contraception options and plans to conceive at some point in the future. Just as we should inform patients of the risks of the contraception methods available, it is equally important to inform them of the risks that come with pregnancy. Even though there are obvious risks to the future child, like death and suffering, as I pointed in the beginning, in practice, this conversation would focus on the risk to the mother, since this is the patient in front of you at the moment. I generally divide the risks of pregnancy into the common, less common, but not rare, and the uncommon. This allows people to have a better idea of what can happen realistically and make a more informed decision. Of course, this list is by no means comprehensive, given that pregnancy has dozens and dozens of potential risks. Because people may not be expecting you to bring these risks up, it's useful to normalize the discussion with something like, since pregnancy is a major change in the body that comes with inherent risks, I usually go over these risks, especially when it's a first pregnancy. This helps you be better informed before getting pregnant and gives you space to ask any questions you may have. Again, the goal here is not to coerce, but rather to present the reality of the situation so that people will give proper consideration to this paramount decision and be better informed. If you want to be complete, I suppose you could also discuss the benefits of pregnancy, though medically speaking, there are far fewer benefits than risks. From a practical perspective, you would likely highlight the most common risks and those risks your patient would find important, according to her values. In the case of this example patient with a history of hypertension and obesity, you may want to highlight preeclampsia and other complications that are more likely to be seen in the setting of her comorbidities. Even though contraception counseling is mostly thought of as an outpatient interaction, there are a lot of inpatient opportunities to bring this topic up. We just have to be mindful enough to bring it up, especially if it is at a point when the patient is more likely to pay attention. Here are a few examples. If the current admission problem puts the patient at a higher risk pregnancy category in the future, were she to get pregnant, this is worth pointing out. For example, if she was admitted with diabetic ketoacidosis or another diabetes complication, and she is of childbearing age, it is reasonable to ask about contraception with the intent of informing the patient of the higher risk of a complicated pregnancy were she to get pregnant. The use of a teratogenic drug, such as tobacco or excess alcohol, or having been prescribed a teratogenic medication, is also another opportunity to discuss contraception. This can apply to both men and women because exposure in the household may not be limited to one person. Although most STIs are treated in the outpatient world, when these present as part of someone's inpatient admission, this is yet another opportunity to talk about contraception. And of course, obstetric admissions and discussions of future contraception options are also important not to miss. One final point I would like to make. Having antinatalism in mind when practicing medicine is usually not glamorous. There will be no adrenaline rush. No one will call you a hero or praise your expert clinical skills. But you will have helped prevent a lifetime of suffering. You will have truly saved a life. You will have done the right thing. In summary, the principles of ethical antinatalism should be applied to clinical practice, given the tremendous positive impact they can have in the reduction of suffering. By far, the most valuable tool to do this is contraception, but this is most effective when coupled with compassionately delivered information that allows patients to make their own decisions by being aware of the risks these decisions entail. Think of all the suffering we could prevent if all of us, as medical practitioners, discussed contraception more routinely. We could actually save lives and spare incalculable suffering from those not yet conceived. Because we can do better than simply help stall death for those already here. We can prevent death and suffering altogether. I can't think of better preventive medical care than that. Thank you very much for watching. I hope this presentation was useful. Feel free to leave any constructive feedback below or share your experiences or clinical tips related to this topic.